and be talking a bit about some of the continued state changes as some of the focus, as well as revisiting a few of the points from before. So as always, CME, covidcme.dhs@maine.gov. We have no financial disclosures. So this is one of the big things in terms of the format. So we've been saying for a while that we're going to back off the weekly sessions. Whoops, somehow went backwards there. What's going on? It seems like it's time to do that. So we are going to move to twice a month, starting in April. So this is the last week of March. So there'll be no session next week, and then on the second and fourth weeks after that. So I put the dates there. We do continue to host the DHHS Health Equity webinar on the third Wednesday of the month. And that's at 7:30. So there'll be something that week. Again, nothing next week, just as a reminder. We will continue to record and post the sessions onto the CDC website as always. So we'll have Dr. Sears giving us just a few quick reminders about the existing vaccines, and then just touching base a bit about viral variants, and then talking again about ongoing changes in terms of distribution at the state and efforts we're making to leave no one behind who wants a vaccine. So Steve, just quick on
Great.
these.
Thank you. And good morning, everybody. I think we've seen this slide a bunch of times, but it just shows you, if you want to refer back to it, what the differences are between Pfizer, Moderna, and J&J. Probably the two biggest are J&J's a 1 dose, the other two are 2 doses, and that Pfizer can be given to 16 and above. They also then have storage requirements that are different. Otherwise, pretty similar. The most important part of this is when you look at the efficacy against severe disease. If you look in the middle, hospitalization and death, these are all of these vaccines that we have, and even those that are coming along are 100% effective or appear to be so far, which is really great news overall. The next slide really starts talking about variants, and oops, it doesn't. It actually talks about, yeah, you did. No, that's okay, because I think I sent you that data. That slide's important because everybody keeps asking about it. We're getting more data. These are small studies, some published, some in the news. The question is, how well does the vaccine prevent asymptomatic transmission or even asymptomatic acquisition? And the more data we get, the better it looks overall. And I know that there's some more studies to be coming, but at the very least 75%. And there's a new study coming out that shows that even in nursing home patients who had 1 dose, the levels of virus that they have if they've responded to the vaccine are dramatically decreased if they have it. So I think the unanswered question that was started out with these trials is, does this prevent continued transmission? It looks like it's going to be really pretty good at doing that. Is it perfect? No. Is it perfect in preventing all disease? No, but really very good on both counts. So what about variants? I guess I would only say that there's 2 ways to think about these. One is variants and one is scariants. And some people are getting very scared of these. Should we be? Well, I think let's start by saying, why are they important? Let's assume they are important, and what can we do about it? That means we need to continue to use masking and physical distancing, try to prevent transmission, get vaccine out as fast as possible, because if we have vaccine, if you have protection, then we're going to, as we just saw from the other slide, we will have decreased viral acquisition and decreased replication, and therefore decreased possibility of viral variants developing in the first place and then being transmitted. So the vaccines really do play a very big role. Are they 100% against all the variants? Not really, but the one that we're most concerned about is the B117, and then all the 3 vaccines appear to be very effective in still preventing that disease. This is a slide from the American Public Health Association. It's one way of looking at this. But I think just want to emphasize these are RNA viruses. We expect them to mutate. Several mutations together are probably going to potentially create a variant. A variant may well have some survival advantage for the virus, and they may become the dominant strain overall. They replicate more than DNA viruses. SARS-CoV-2 doesn't do it that fast. It just is transmitted a lot. We've had millions and millions of infections, and therefore the potential is there. The neutralizing antibody titer of both Moderna and Pfizer, by and large, looks like it's pretty effective against the variants that we're seeing. The one that's of concern is the South African, but that's not really transmitted greatly in this country yet. And I know these vaccine companies are actually looking at potential boosters that would be even more effective against those. But probably more importantly, and I think this is the emphasized by Dr. Gandhi, is don't forget the T cell. We are not monitoring and measuring T cell responses. We're looking at B cell antibody responses. This response with these vaccines is highly dependent also on Th1 responses. And so they have still appear to be quite effective. And I think the other point that she wanted to make is, why we should not be overly worried. She didn't say don't be worried, but that these we will have time before one of these variants becomes the dominant strain to probably produce new vaccines and or tweak the vaccines that we have, because that's exactly what we see going on right now. The next slide, though, is the worried side, okay, the scary side. The CDC is very concerned about these. Could they be behind driving the spikes in cases that we're seeing? It's hard to sort it out, because there's also been clearly a decrease in social distancing and masking around the country. Probably a combination of the two. We have seen transmission of variants of concern. The ones we're most concerned about is, and I wish that we had better language for these. That's why we end up calling them by the name of the country, which is really not all that fair, but it's like B1117. That's the UK variant. That was where it was first identified. That's the one that's most common in this country and is growing pretty dramatically in certain states. South African B1.351 has been found around many other countries, certainly in African countries and the United Kingdom itself. And P1 is the Brazilian variant. And I think we've all heard how awful the pandemic is in Brazil at the moment. It's partially because of the P1, but it's also because of the political decisions that they've made regarding controlling the pandemic. The variants often contain this thing called E484K. It's a mutation. It helps it be somewhat evasive to our immune system. How that's going to play itself out, because that's also seen in some of what are known as the New York variants, which are seen in New York. And we also need to add to this list that there are California variants. And I say that because they're going to be variants, and we're just going to have to keep watching them, monitoring them. And then if we need to develop something for them, we need to. So I'm sure there's more to come on that, but I'm going to turn it over to you, Lisa.
Okay. So yeah, we just thought we'd give the flip side of worry less, worry more. Get vaccinated is the bottom line. So get people vaccinated. Hopefully you've all seen by now, we are in the 50 and over for the past week or so, plus school teachers, staff, childcare, and then April 19th, everybody 16 and older, which clearly then raises some issues about children. So I'm going to turn it to Amy for a few minutes and then come back and talk about other activities the state is doing to support vaccination for anyone who wants it. Amy.
Great. Good morning, everyone. So as you know, there's several vaccines that are available, but the Pfizer vaccine is the only one that currently has emergency use authorization for the 16 to 18-year-old group. And so we're going to need to direct that age group to sites that have Pfizer at this point. Moderna and J&J is available for 18 and older. There are current trials right now for the younger population. The Pfizer Moderna trials are fully enrolled for the 12 to under 16 and 12 to under 18. And actually Pfizer just opened up trials last week for the 6 months to 12 years, and Moderna also has an open trial for that age group. Once J&J has completed their trials for the 12 to 18-year-old group, they'll go to start the trial for the 6 months to 12 years. We are not clear when these vaccines are going to be opened up for children under the age of 16. I think what we're hearing just anecdotally is probably we're looking at fall, winter time, but it may come sooner for some of those age groups. As you're looking to do the 16 to 17-year-olds, some of the key things that we're getting a lot of questions on, and I know the health systems are working on, is the consent that's required. You're going to need to obtain consent from a parent or caregiver in this age group, whether or not it's written consent, electronic, if you're signing people up electronically, or via telephone. I think currently Northern Light in this age group, especially if they've had childcare workers and school staff, they are doing it by phone and getting a phone consent. There is a group of emancipated minors, so we are talking about what proof will be needed. Another issue is around a picture or photo ID. What kind of identification might a minor have if they don't have a driver's license? So we'll be putting some guidance out around that. The other thing is when you're signing the youth up, in some places, if they're not going to have a parent accompany them, I think that will be a decision as to whether or not a caregiver should accompany them for a vaccine. But if not, making sure that you have an emergency contact in case somebody does have an allergic reaction or you need to reach a caregiver if a youth is getting a vaccine that's not accompanied by a parent. The other thing that we're going to need to work on is, because they only can get Pfizer vaccine in the 16 to less than 18-year-old age group, many of the Pfizer allocations are going to the large throughput sites. We're going to need to direct those individuals and parents and caregivers to those appropriate sites to get vaccinated. And some other things that we're thinking about right now are also just communication strategies in this age group. So how to reach young adults and make sure that they are getting vaccinated. I'm sure that you have seen just generally in the case counts, we're worried about the 20 to 30-year-old age group in terms of case counts going up. And so just trying to reach young adults generally, and how do we message out that group? Go to the next slide, Lisa.
Yes, I was just going to talk for a few minutes about some of the strategies that we're taking at the state to try to get at this issue of getting the vaccine out as widely as possible. I think we've seen, as each of the age brackets have opened up, there's a big demand, there's a big rush, and then we hit some number between 30, 50, 60% of people in that age group vaccinated, and certainly the higher the older ages, the higher the demand. So as we move down the brackets and then open it up in just a few weeks, how do we continue to get it out widely, both through our messaging, communication? Amy just talked about, for younger people, there are ongoing efforts at the state about how do we get more messaging out there, and then other strategies as well. Again, this notion to truly leave no one behind. So one is the notion of health equity pop-up clinics. You may have, I think I might have mentioned this last week, but the state announced this, I think, last week, where community organizations are invited to apply to host what we're calling pop-up clinics, specifically with an equity focus. So I know we're seeing some applications from others who would like to do this, at work sites, but for right now, the primary focus is on diverse communities who otherwise may have difficulty accessing vaccine. This still follows the governor's eligibility phases, but obviously in just a few weeks, it will be all ages. And then applications are reviewed, and the selected applications are linked with an MIP approved vaccine provider. So those of you who are vaccine providers may be getting requests to work with community groups to help plan these. The community sponsor is responsible for selecting the site, planning the logistics, providing the volunteers and staff, cultural brokers, interpreters, and again, the idea being trying to get diverse communities into sites where they might not otherwise go to, say, a large site, or perhaps in a more rural community where they're not going to travel. It's been really striking talking to some communities, and I'm sure you all know from talking to your own patients, some patients just aren't going to travel. They are going to wait for the vaccine when it gets to their community, and they are not going somewhere else. So this could be helpful in some of those as well. And then again, the vaccine obviously has to be provided by an MIP approved provider. Primary care distribution, I know there's been a lot of interest from primary care sites. We are continuing to make plans for that and have more discussions this week with some of the associations. So hopefully more specifics on that soon. I'll just say we are going to need more people doing vaccine, as the amount of vaccine we hear from the feds hopefully steps up considerably in the next few weeks. I think I've also mentioned on this group that we have a clinician speakers bureau to help provide clinicians to support community conversations. Community groups can request a clinician to be part of those conversations. We've got sort of a standard PowerPoint, sort of a community version of this. If folks are interested in learning more, feel free to reach out to me. I've mentioned the community vaccination line previously, so that's still available to help people make appointments. We've shared the numbers there. And then I think last week I mentioned for the first time the vaccine registration system. So vaccinateme.maine.gov. It's, I believe, still open for pre-registration only. You've seen in the paper, we've had tens of thousands of people pre-register.
Yes, thank you. Yeah, I don't know.
Whoops.
I don't know if I just, like, I had a busy weekend and I didn't
Amy, can you
sleep
help
good
me?
night.
There we go. Okay, thanks for that. I think I'm unmuted. Yes? Good? Okay, thank you. So the state is working with vaccine providers who want to use the schedule to allow people to schedule. So that is in place and will be expanded in terms of its functionality soon as well. And transportation we've mentioned before. Just a reminder, people have to call 48 hours in advance. They do drop them off back at 60 to 90 minutes. And I'm trying to see, did I have one other thing there about the contracts with community organizations. So DHHS has also been contracting with particularly ethnically based community organizations around the state. Initially, a lot of work there was about trying to get people tested, quarantined, social service supports, but now there's a second round of contracts to many, but not quite all of the same, but many of the same organizations to do, again, outreach. So supporting these pop-up clinics, for example, doing community conversations, cultural brokering to help people get into vaccination sites. So that's a little bit, I think more quietly in the background, but know that that is out there as well. We also continue, I mentioned, to host the equity webinars. We'll be doing the next one always on the third Wednesday, so April 21st, and we'll have another clinical and ideally community group talking about what they're doing. And that's pretty much it. Information on the governor's website. One more plug that we are moving to twice a month on these sessions. So this session not happening next week, but then mark your calendars, the second and fourth weeks of the month, the same times, Tuesday mornings and Friday afternoons. We'll continue to record and post info on the CDC website. So let's stop sharing and go to questions.
One of the first questions is about the CME. You should be getting an email from the Maine Medical Association where they're sending out the survey to complete. So we'll have to check on that. At least I don't know further.
They group that up. So what happens on our, when you send that email, it gets tracked at DHHS. They send the list to the Gail Began, the Maine Medical Association. And then they did it once at the end of January. I'm not sure they did it at the end of February, but now end of March, you definitely, I'll check with Sabrina, make sure that you should get an email from Gail Began at the MMA to just do this brief evaluation. And then the association sends you the CME message. So it definitely could have been a little while just because rather than do it every week, they group it up, but you should see it soon. I'll double check on that.
Question for Dr. Sears. Since the vaccine doesn't prevent someone from catching the virus in the near future, is there a reason to worry about the virus mutant individuals who've already been vaccinated? You're on mute, Dr. Sears.
No, I saw it again. Thank you for the question, Charles. Let me just try to change the way of looking at this. I think the vaccines actually really do prevent the majority of infection. And in those who get infected, it's probably very low levels. That's really what the data is showing us so far. So could the virus that replicates in those individuals have a higher propensity to become mutants? I don't know, because they're not replicating at high levels and it's not a large number. The place actually where the concerns have been the most as far as the quote development of mutants has been in people who are immunocompromised, because they may not be able to fight the virus off at all. I think it's a good question. We'll really need to see, but my suspicion is that that's not going to be a major driver of variants.
Great. And there's a couple of questions about the pop-up clinics. One is there a link that we can share in the chat box around the announcement and how to apply for the pop-up clinics? And then is there a form for the vaccine providers to connect with community organizations interested in arranging pop-up clinics? Like how will that match up happen?
So I will put I'll put the link in for the pop-up clinics. And again, remember, this is primarily for community organizations to apply, but that absolutely can be shared. And then the matchup happens on the back end through the Maine immunization program. So, so Liana Amayas, our director of diversity, equity, inclusion, with a small team internally reviews the applications, sort of prioritizes them, and then hands them over to Maine immunization program, who then, and we do ask, I believe, on the application, which you can see in just a minute, as soon as I can find it, do things at once, that they name if they have any, provider partners as well. So there's some opportunity there for that, matchmaking to be initiated, but then MIP looks through either relationships or geography and reaches out to the MIP provider. So if you know community groups and you want to be their vaccination provider, certainly, feel free to have those conversations and encourage them to include that in their application.
I would say if this is something you're that
There's
you're
Liana. I didn't realize you were on there. Sorry.
it's okay. I was just going to say that if this is something your practice is interested in being paired with community organizations hosting these clinics, that I think it would be fine to send an email to myself or Maine Immunization Program Maddie Squibb and let her know that your practice is interested in this, so that we have an awareness of that as we're reaching out to providers to match them with community-based organizations.
Thank you, Leon. I didn't realize you were on. Thank you. And there's the application.
And Dr. Sears, have you heard anything more about the observation period for J&J vaccine, if the CDC is looking at that and whether or not that might change in the future?
Good question. Just to frame that, when we first got the two mRNA vaccines, Pfizer and Moderna, we knew that there was some anaphylaxis that was associated with it. We didn't really know how much it was. We've gotten now more experience, and so it's more than the average like flu vaccine, but it's still incredibly rare. J&J, there was only one case reported in the entire series of the trials, but we are collecting significant amounts of data as it is provided around the country. And the answer is, yeah, I think we're going to see the time frames for having to observe people dropping, because I have not heard and have not seen anything written. Really what will happen most likely is the MMWR will come out with a compilation of what's really seen in the real world as far as side effects. And I've not seen that yet for J&J. We did see it for the mRNA vaccines. So probably coming soon.
There's potentially another question for you, Dr. Sears. Clinical checklist by the CDC added dermal fillers. Could you explain why this is an issue and what's the time period if they had a dermal filler within 3, 5, 10 years ago? What's the age? What's the concern in terms of timing on that?
Yeah, I see Dr. Panoia there, and so I'm going to have her answer. I can answer it, but I'm going to see how she does.
Nice lateral.
I won't do as well as Dr. Sears. There are reports of edema developing around areas where people have had these dermal fillers placed. And so they think it's related to a polyethylene glycol cross-reactivity in the vaccine. So that is why this precaution is there.
Peggy, is there a time frame in terms of when they had them to?
It looks like they're saying 3, I don't know if there is a known time frame. Those things don't last indefinitely, but I haven't seen anything report about time frame. So I think I have to turn that over to Dr. Sears. I'm so sorry.
Yeah, I've not seen time frames either. I think it's not a reason to stop, to not give the vaccine. It's just a reason to note they might get some swelling around the dermal fillers and know that that's going to happen. So I think it's really a question of letting people know.
And just to be clear, for plain language, that's like collagen injections in people's lips and cheeks and things.
Resulin, right? And those sorts of things. Yes.
I'm clearly exhibiting my ignorance on
not something I think of all that commonly, but
Another one for Steve, maybe, Amy. How's the state doing? National news shows us in the group increasing the most.
I think we're doing incredibly well. If you look at the governor's webpage, actually tracks this on a daily basis, what the percentage of people who've gotten final doses, individual doses, and where we are overall, and and added to that, in that we are getting a huge amount increase this week, but we think we have the clinic set up to be able to handle that. So I think that there are a couple of states around the country that seem to be doing better on a per capita. You have to look at this on a per capita basis, because if you look at Massachusetts, they've given far more vaccines, but if you look on a per capita, not so much. So I think we've got all of the right things in place. We've got great volunteers. We've got great partnerships with the health clinics. We've got a lot of these new ways of trying to get to more diverse communities. And we're now going to be getting more vaccine. At least this week, we're getting a significant increase from last week. And we're told that into April, which is only actually the end of this week, we will be getting increasingly larger quantities of vaccine. And our job will be to make sure we can give it to everybody. I think it's
Steve, I'm reading the question also as cases, though.
Oh, cases.
I'm reading it that way.
Sure. I was thinking vaccine, since that's what we were talking about. But cases, the way I would describe this is we had large numbers of cases in the middle of January into the beginning of February. That declined. It declined to about 200 cases a day. Everybody was hoping that would continue to decline, but we plateaued. And we actually see up and down bumps. And so we've had what I would say overall is on per week basis, an increase of number of cases, and we're also seeing a slight increase in our positivity rate. But it's bouncing around at the moment. So I don't know which way that's going, or whether we're stable. Having said that, stably is not a good place. If you think back to in early summertime, when we were, late spring, early summer, we were concerned, we're seeing more cases per day now than we clearly were back then. So more work to be done in trying to prevent this disease.
Yeah, which certainly is linked to the need to get out vaccine more. So we really appreciate everybody. It's just been a giant collective effort in the state. Clearly, we could not do it without all the partners that we've had. To that end, I also wanted to use these last 2 minutes to maybe do a mini little critique of how these sessions have been going as we back off to, twice a month. Does that sound right? Are there specific topics, ways we could improve these sessions? What's been helpful, what's not? Anybody wants to really unmute, feel free to jump in or put suggestions on chat. I just put a little prompt there, but any feedback? It's been going since December now.
Imagine.
Any particular topics or nice comments here, but
This is Deb Silverstein. I just want to say quickly, these have been great sessions. As a vaccinator, just to be able to check in every week and get updates has been very helpful. As far as future topics, ongoing updates are extremely helpful, and the opportunity to ask questions of the experts is very valuable. So thank you.
great. Well, luckily we've got a few of those on the call. And all of you. Great to see you,
Yes, you
Deb.
are.
I didn't mean me. All right. Well, with that, it's a quick review could take less time. Questions. Yes, that's a great point. Yep. Okay. All right. Well, it is end of the half hour. So thank you all. We will be doing the session again on Friday. Again, if anybody has other suggestions or specific topics, always feel free to email me. I just put mine in there. I think you know it now, but lisa.letourneau@maine.gov. And we will plan to be back on Tuesday, April 13th. Thanks so much.